Hello and welcome to the Dr. Mech Anesthesiology series. Today, we're going to break down a really interesting head-to-head clinical trial that pits a new challenger, Remimazolam, against our long-standing standard Propofol. Okay, before we get started, just the usual reminder, this content is for informational and educational purposes aimed at our colleagues in the medical field. Our analysis today is based on a prospective, randomized trial by Liang and colleagues, which is published in BMC Anesthesiology. So here's how we'll walk through it. We'll start with the context of day surgery, profile the two agents, then look at the study's design, compare the key clinical outcomes, and finally wrap up by discussing what this all means for our practice. All right, let's set the stage. You know, the whole landscape is shifting. The incredible growth of day surgery and the widespread adoption of enhanced recovery after surgery, or ERAS, protocols have really changed the game for us. It's raised the bar for what we expect from our anesthetic agents. The name of the game is efficiency and safety. We need to ensure patients have a smooth, rapid, and predictable recovery. This means we're constantly searching for agents that aren't just effective, but also offer exceptionally high safety margins, especially concerning things like hemodynamic stability. And that search brings us to the two drugs at the very heart of this trial. We have our established workhorse, Propofol, squaring off against the novel challenger, Remimazolam. So let's put these two side by side. Now, they both work as GABA A receptor agonists, but that's where the similarities start to fade. Propofol is an alkyl phenol in a lipid emulsion, which, as we all know, is notorious for causing injection pain. Remimazolam, however, is a water-soluble, ultra-short-acting benzodiazepine. And here's the kicker, the real game changer. Remimazolam has a specific reversal agent, flumazenol. That gives us an incredible safety net that we simply don't have with Propofol. So how exactly did the researchers set up this comparison? Well, Liang and colleagues used a very solid and robust study design to get their answers. It was a prospective, randomized, controlled trial designed to test for non-inferiority. They enrolled 100 relatively healthy patients, specifically ASA grade 1 and 2, all scheduled for short day surgeries lasting less than 2 hours. Then, they were randomly assigned to one of two groups. One received Propofol, and the other received Remimazolam for both induction and maintenance of anesthesia. Okay, so what was the main thing they were measuring? Their primary outcome was something they called anesthesia success, and their definition was very strict. To count as a success, the patient had to have zero intraoperative awareness, no need for any rescue sedatives, and absolutely no involuntary movements. It's a really clear, clinically meaningful endpoint. All right, this is the part we've all been waiting for. Let's dig into the head-to-head results from the trial itself. And the top-line result is pretty striking, 100%. Both groups, Propofol and Remimazolam, achieved a 100% anesthesia efficacy rate. So right off the bat, Remimazolam proved it was not inferior. But of course, that's just the beginning of the story. The really interesting details are in how they performed differently. Now, here's where we see the first key difference. The time it took to achieve loss of consciousness was significantly faster with Propofol. We know Propofol is fast, and this study confirms it. It's definitely something to keep in mind when a very rapid onset is your top priority. But then, a much more critical point of difference came to light when they looked at hemodynamic stability. And this, for us as clinicians, is where things get really, really important, especially when we're managing sicker or more fragile patients. You are listening to the Dr. Make series. If you look at the data here, you can see that at the point of losing consciousness, the drop in both mean arterial pressure and heart rate was significantly greater in the Propofol group. And that difference persisted. Even 30 minutes into the procedure, the map was still significantly lower for patients who received Propofol. And this chart, this really tells the clinical story. That hemodynamic instability we just talked about had a direct consequence. A significantly higher number of patients in the Propofol group required vasopressors to support their blood pressure. The Remimazolam group, on the other hand, was far more stable, requiring much less intervention. Now, moving on from the hard numbers on hemodynamics, there was another major difference, and this one has to do with the patient's actual experience during induction. The results here are just night and day. Look at this. Injection pain, that common unpleasant side effect we see with Propofol, was reported by a staggering 80% of patients in that group. Compare that to just 4% in the Remimazolam group. I mean, that's a massive improvement in patient comfort right from the start. So you might be wondering, with all these differences during the procedure, Does Remimazolam slow things down on the back end? Well, the answer is no. And this is crucial for day surgery. The study found no significant differences in recovery times, not for eye opening, not for extubation, and not for the length of stay in the PACU. So after looking at all that data, what does it really mean for us day to day in our clinical practice? Let's distill this down to the key takeaways. Let's start with the author's own conclusion. They state that, compared with propofol, Remimazolam is not inferior in terms of safety and efficacy for these short procedures. And critically, it doesn't cause a delayed discharge even without using flumazenol.
So let's summarize. First, Remimazolam is a viable, non-inferior alternative to propofol. Its biggest advantages are that superior hemodynamic stability and the dramatic reduction in injection pain. Then there's that huge safety advantage of having a specific reversal agent. The main trade-off, as we saw, is a slightly slower onset of action, which is just something we need to factor into our planning. You are listening to the Dr. Mech series.
If you found this breakdown of the latest research valuable for your practice, please make sure to subscribe and enable notifications. That way, you won't miss our future deep dives into pivotal clinical trials from the Dr. Mech Anesthesiology series. And that leaves us with a really important question to think about. When you consider its unique profile, that superior hemodynamic stability, the enhanced patient comfort, and the safety net of a specific antagonist, could we be looking at the future standard of care for general anesthesia in the day surgery setting? Thank you for listening.